Hello, I'm going to real quickly go over these chief complaint sheets, diagnosis sheets that you guys did. Let me just tell you, for the most part, these were fantastic. The only problems we had was just some more technical issues and some things that I want to talk about. One, whenever you say anything in a piece of paper, you need to cite it. And the in-text citation is needed before you put anything in a reference table. So just make sure you're giving wherever you learned this information credit for what you learned, okay? So, and then if I see some other things, there's a few other things I wanted to mention to you as far as like the technical APA stuff, but most part, everything here looks really good. So, I want to talk to you about this one, otitis media, acute otitis media. Super common. So basically this is, and I tried to put in yellow, highlight maybe some extra information that I put in here. So your inner ear, which they've got a nice picture of you here, so you get like mucus, you have a cold or you get congestion or whatever else, and you get mucus kind of coming up here and it gets trapped in here. So this is a nice warm dark environment. You've got mucus in there, which has got a sugar content. And if your eustachian tubes for whatever reason are plugged, say you're congested, they're plugged, everything's kind of like a little edematous, then that sets this area up for developing the bacteria to grow to develop an otitis media. Okay, so in kids, and you can see this is an adult picture. So in adults, adults don't get ear infections often because you can see that the snot or whatever would have to go up and kind of go uphill to get into this inner ear part. Where in kids, this eustachian tube really, let me just, got this drawing tool here, it's shorter and it's straighter, okay? So if a kid's laying down drinking a bottle particularly, it's just a straight shot down to get in there and get affected, okay? Let me see, I think that was, trying to get this off now. Alright, so let me just kind of go down here a little bit more of his paper. The etiology, super frequent, occurs more in children, of course. So look this over. The biggest thing here is you're going to look at, this is really by physical exam. So you got a history of someone with ear pain, and then they have a fever. Now, if they have ear pain, or if they have ear pain and they have a fever and everything else, and you see this one here, you're going to treat. If I saw this ear here and I said there was no fever and I said, does your ear hurt? They go, no, it doesn't hurt. I'm just going to watch this one, okay? Now if I see this, there are some people that just have a super high tolerance to pain. If I see this, I'm going to treat whether they're having pain or not. Can you see the difference? This has still got some clear fluid behind it. This can go either way. This has got a lot of pus behind it, okay? So based on physical exam is how I'm going to treat this one. So this is just fluid. We're never going to treat this, okay? This is a little fluid. This is super early. We're going to watch this. And if I saw this on physical exam and they didn't come in with a complaint of ear pain, or they weren't saying anything about congestion, I wouldn't even mention it. If I do have this and they do have a complaint of ear pain, I'm not going to treat this with an antibiotic. I'm going to give them an antihistamine decongestant, okay, to kind of open up that to decrease the inflammation in that eustachian tube and allow this fluid to drain. Does that make sense? Okie dokie. Then they've got a good differential here. Perfect. Alright. Alright, allergic rhinitis. Once again, the pathophysiology is kind of explained here. Very nice job. Basically, it's part of the histamine allergy cascade. If you don't know about that, read about it because it's kind of interesting and it'll affect so many things, okay? How it's diagnosed, once again, this is basically diagnosed through physical exam. You can go ahead and check for the allergies to find out what's going on there. Typically, I don't check for allergies or even recommending allergy testing unless the allergies are causing major issues. I think particularly here in the South, almost everybody has some sort of allergy. We have so much ragweed, and our climate here is so mild that it doesn't really kill off things, and so most everybody has some sort of symptoms related to this, and 1 in 6 individuals, and and I think that if you did it in this area, I bet it would probably be more like 4 in 6 individuals. So anyways, that's kind of what's going on here. So with this on physical exam, you're going to get the that little nasal crease. You're going to get those little dindy lines under the eye. You're going to have the allergic shiners. You're going to have cobblestone in the back of the throat. You're going to have pale turbinates when you look up their nose. So it's all kind of physical exam, and then the history of like congestion, runny nose, stuffiness, maybe a little sore throat. Okay? So brachial cleft abscesses. This, he did a good job with these. This is like an off-center, not a center. So if you have a midline abscess in the neck, it's not this, okay? So this is an off-center abscess. Sometimes they can be quite small, like a little lump either side of the trachea on the neck. And this comes from, there's 4 brachial clefts that are formed during the embryo stage. If you remember those really small embryo kind of things, and they almost have those little folds on the top of that head-looking thing, that's kind of what these are. So they're remnants there, and if they don't completely seal off, they can get pus and stuff down in them and become infected. You can treat these with antibiotics, and they will get better, but they'll come back. So really the treatment for these is to excise the area so that it can't reoccur. Okay, so the epidemiology here, I thought this was kind of interesting. They put, oh gosh, what was it? 1 in a million per population per year. I have seen this at least 3 times in my practice, and in the NICU we've seen it as well. But it's an offset, and it makes me wonder if this is just underreported. But yeah, if you see one of these and you diagnose this, you will look pretty smart. All right, so the best that you get an ultrasound or CT scan, that sort of thing, and then the differential diagnosis is some kind of a lot of other kinds of infections, basically, and definitely tumors and things like that. So anyhow, this was pretty interesting. And I think he's got some pictures down here too. Now there's one. Now these are pretty big, what he has here. And that almost looks more like a cat scratch fever to me. The way that's a unilateral lymph node there, or node there. But I guess this is not, because he wouldn't include this picture if it was. The other thing that you can get is cat scratch fever will give you a big unilateral lymph node enlargement there. But you'll also see this with tuberculosis. There's like a it's like a cutis type tuberculosis. We've seen this once in our practice. We had a kid that we thought was cat scratch, sent away the Bordetella titers, wasn't that, and then going down the differential did TB, and sure enough, that's what it was. So that kid actually went to infectious disease. It was kind of interesting. Conjunctivitis, another super common complaint. And let me just tell you, some of these diagnoses had duplicates. They weren't really supposed to. That was my bad instructions about who should do what. But anyhow, the whole idea was for you guys to learn something about at least one of these, and hopefully you'll look at your peers and you'll learn something about a little something about all of them. But this is an infection, either viral, bacterial, or can be related to allergies. This is the pink eye. You'll hear people calling them that. Typically, and they've got like the viral. The viral is definitely more common, and typically when you have viral bacteria, you have one eye. When it's allergies, it's usually 2 eyes, and they have a really good. The viral conjunctivitis has this watery discharge, and they are typically more red and look more yucky, basically. The bacterial has the purulent discharge, and the conjunctivitis is the itchy eye, okay, along with other kind of allergy kind of symptoms. Good little breakdown here. This also a good thing on differential diagnoses. Just a good job, okay? Tooth abscess, and actually you can see this in all ages. You can even see it in kids that haven't actually had a tooth erupt yet. You can see this. Usually it's very tender. If you open up their mouth and you actually just get like a tongue depressor and you kind of tap on the area, they'll tell you. Sometimes you can actually just IND these in the office and put them on antibiotics and send them to a dentist. You know, start them on antibiotics while they're waiting for the dentist to be seen. We can definitely do that. Usually that tooth is not going to do well, but that's more for them to do. This is also just a diagnosis of pretty much from physical exam. You can see that jaw swollen, which could be a whole bunch of other things, right? They got some good differential diagnosis here, but you'll see that abscess, and you kind of touch on that, or you touch on that gum around there, and they will let you know it hurts. Okay? Good job. Now, some of the things that you can see when you're looking at an eye, and we have a pan-ophthalmoscope, which during the intensive you will be able to look in the back of people's eyes. Hopefully you won't see anything like this. But if you need to know what normal looks like so you can see what abnormal looks like. Great idea. Basically diabetes, and we've also got one here on hypertension. Diabetes and hypertension. This might be is this hypertension? Yeah. Diabetes and hypertension are not good for your eyes. You got little tiny blood vessels back there. So hypertension can cause the thickening of these arteries and veins, and you'll also can get more proliferation of veins and into this area, back area of the eye where you shouldn't have any. Okay, so definitely could see that. Talk about the epidemiology here. Definitely, some of the risk factors we don't, and that's basically the risk factors for hypertension, which is really common in this area. So you need to look in some eyes so you can see what normal eyes look like, so you can tell when there's a problem. And then these people with hypertension do need to follow up by their ophthalmologist or optometrist or whatever they call them. Acute otitis with effusion. We kind of talked about this with acute otitis media. Basically, this is just the fluid. And so that picture I showed you earlier is kind of what it would look like and how you would treat it. Got a good differential diagnosis here. Cholesteatomas. I did not put these on this list. I don't think I did. If I did, I don't think anybody did it. But these are kind of interesting. If you see anything three-dimensional on the ear exam that's white, three-dimensional, then that needs to be referred to an ENT, because those things can be pretty serious. I've actually diagnosed 2 of those in children, so they're not that uncommon either. Okay. Okay, acute otitis with acute otitis externa. Super common in the summertime, and this is basically the way it looks. You can see this kind of debris looking stuff in there. Sometimes it's so swollen you can't see anything. You just put your otoscope near their ear and they go crazy. These are very, very painful. Just to kind of a side note, when you're treating them, you have to treat it for a good 5 days before they're really feeling better. These can be fungal. That can be really interesting to get rid of. You actually have to kind of take something like a powdered Lotrimin and kind of blow it into their ear with like a kind of like a duster type thing, like you would put makeup on. You can use one of those ear syringes and kind of blow it in there. I've only ever had to do that a couple of times, so it's not super common. It's more can be treated with just the normal medications. But these are super common, especially in kids. They can happen even in clear pools, so don't be, you know, if they say they were in a pool that had chlorine, it doesn't matter. They can happen, you know, even in a chlorinated pool. It doesn't show that there's bacteria in there. Okay? Well, they've got herpes and hand, foot, and mouth disease, and actually they're two different things, but they're very much alike, and I was going to talk about them together anyways. They're both pretty much from the Coxsackie virus, but herpes angina is just the mouth. Hand, foot, and mouth is the hand, foot, and mouth, okay, where you get little blisters, hand, foot, and mouth. With hand, foot, and mouth, it's actually hand, foot, and mouth bottom. You'll see these on the buttocks too, and also on the outer lips. And so you can see herpes angina on the outer lips as well. So it's basically a diagnosis of physical exam. Usually have a history of a kid with a fever, now not eating very well, drooling perhaps, and you look in their mouth and you're like, oh my gosh. And you check them for strep just to be sure. They don't have any pictures of them here, so maybe I'll look at the other one and see if it has pictures. Alright, ductal stenosis is basically a clear, clogged eye lacrimal duct. So you know that your tears are made at the top of your eye, they flow over your eye, and they drain down in that little duct there beside your nose. And if that duct is not open for whatever reason, talk about decannulation, then the tears will spill over. You get crustiness, usually not a lot of redness. So they'll be kind of like just teary, but not super, like the conjunctiva is not red or anything, although it can get infected and get red for sure. Usually if it's just ductal stenosis, and typically what I do is treat it one time like it's a conjunctivitis. If it doesn't clear and it's still, if the conjunctivitis doesn't clear up and there's still just this gunky eye, but the conjunctiva is not really red, then it's like it's ductal stenosis. They say you can massage the ducts to kind of clear the deposit or whatever, to kind of cannulate them. I'm not sure that really does anything besides give the parents something to do, but it does give them something to do. So usually this is cleared by a year of age. If it's not cleared by a year of age, then we need to refer these folks to either an ophthalmologist or an ENT that does that, but usually ophthalmology does this. Okay. I can't scroll up because for whatever reason this particular page isn't wanting to open up. So this is the diabetic retinopathy. I'm sorry, I'm having a little TIA there. And it's very much like the hypertensive one, of course, different causation. Just kind of look over this information here. It's pretty interesting. Okay, influenza, super common. We see it a lot, and there is a vaccine for this, but still we're having a hard time getting people to actually take the vaccine. There is A, B, and C kind of influenzas. Usually in the vaccines we have a couple of A's and a B. Sometimes we have 2 A's, 2 B's. You know, they guess about a year ahead of time what those what kind of flus are going to be around. Sometimes they do well, sometimes they don't do very well. They have a thing here on risk factors. Children under 5, older adults, people with chronic illness, pregnancy. Pregnant people die with the flu. They definitely need to take the flu vaccine or have the flu vaccine. Even if it's not perfect, it's the best we can do, right? Healthcare workers. So when it comes to treating the flu, those are the folks who need to get the flu vaccine. When it comes to treating the flu, I'm sending out an announcement to you about Tamiflu later. It's one of my pet peeves. We really need to stick to the guidelines because every year we run out of Tamiflu because given to people that don't need it, and it is not, like all medications, it is not totally risk-free. So you really need to give the Tamiflu to the people under 2, over 65, chronic illness, or pregnant. Okay, and I wouldn't prescribe it to a pregnant person. I'd get their OB to prescribe it to a pregnant person. Laryngitis, another super common one, usually a virus, doesn't need to be treated. Whispering actually makes laryngitis worse. Smoking, of course, you don't want to do that. So just kind of be aware of that. Some of the things you can think about this is like vocal cord paralysis, which you can see, tracheal malacia, which you can see sometimes, especially in children, so you want to kind of be aware of that. But for the most part, if you have acute laryngitis, you just have to kind of watch them and see what's going on. If it continues beyond a couple of weeks, then you probably are going to want to refer this person out. Meniere's disease, or the ringing of the ear, this is really not a good disease, okay? Just because it's not that it's bad, but it's just really can cause depression, some other things like that, because there's not a good way to get rid of this, or at least not that I've found. And you also want to rule out things that it could be a tumor, it could be that. Usually Meniere should be unilateral. If you have bilateral, then you have to be a little bit more concerned about that. You also want to check for hearing loss overall. And so they just got some good information here on it, but just kind of be aware of that. Mononucleosis. Another fairly common disease, usually caused by the Epstein-Barr virus, but not exclusively, so there can be a lot of causes of that. The rapid monospots that we use do check for Epstein-Barr, so it's not 100%. This is one of the things I wanted to put. So just an APA thing. This is, just an APA thing. Like the website writes, or somebody will put, according to Jackson and Smith, or whatever else. The range is this. When it's something that's kind of, maybe not general knowledge, because if it's general knowledge, you're not going to cite it. But when it's kind of like wildly thought, if that makes sense. For instance, this is talking about the cases per 100,000. Cite this at the end of the paragraph, okay? Cite this at the end of the paragraph, or the sentence, excuse me, not the paragraph, because otherwise it just doesn't read right, okay? Now, if it's this person's unique idea, or their study that they did, that's their results only, then you could put, like, according to, like, Jack Spratt, 1 out of 3, in his study, 1 out of 3 women, can eat no flea, or whatever else, you know what I mean? So, but if it's widely recognized, or you're going to find it in multiple studies, or multiple textbooks, or multiple things, don't do it like this, because it's not just their idea. It's not just Hippocrates' idea that this is probably a fairly widely recognized idea, okay? So I've seen this in a lot of people's papers, and that's a common thing to do in undergraduate type stuff. But so, like, for instance, they should be suspected in people. Those are very common, widely recognized symptoms of mono. Okay, so what you would put here is that suspect mononucleosis in patients with da-da-da-da-da, okay? And then cite him or them at the bottom, okay? Does that make sense? Epistaxis, or nosebleeds, another common thing, usually related just to, like, allergic rhinitis, sinusitis. there's a lot of blood vessels in your nose, but it can be kind of serious, and did a good job here explaining the difference between posterior and anterior bleeds. So just kind of look over this and be familiar with it. Normally, and they've also got a little extra section at the bottom here, which is pretty interesting. Normally, you're just going to apply pressure, hold, and it's not going to be a big deal. But you have to worry about it in certain situations, especially people with like hypertension or some other underlying illness. Presbyopia. Now, we did have several people do presbyopia. This is just the first one I came across. So basically, presbyopia is the aging eye. You'll have people that'll have, you know, they've been doing fine, and then they get to be about 40 and they start having trouble reading fine print. They're going to start needing, you know, the readers, that sort of thing. Now there is some sort, if you're normally and I always forget which it is, nearsighted or farsighted. I believe it is farsighted, but I wouldn't swear to that without looking it up, because I have to look it up every time I say it. But if you need glasses for distance, you are going to have kind of a better time when it comes to presbyopia, because your eyes are already angled in a different way anyway, so you're actually going to need reading glasses for not as quickly as folks with normal vision. So that's one nice thing. Normally these folks do not need to see anybody. They can just do the reader kind of glasses. However, because they are also at that age where they're increased risk for glaucoma and other things like that, they probably do need to be checked just to be sure. Okay? I looked it up. Nearsighted is when you see near, far is when you see far. For whatever reason, I always want to get those mixed up. Sialadenitis is inflammation of the salivary glands. Also, not super unusual. We see this from time to time. Usually, once again, it is something that you're going to do with physical exam. So you're going to see this and probably treat it with antibiotics and then see if it doesn't get better. Some of the reasons that you might have it are dehydration. You know, so if you're going to get your mucus kind of thin or thickened. People with like cystic fibrosis would be at increased risk. Sjogren's syndrome. I think this is kind of interesting. My son-in-law to be is doing his PhD work totally on this syndrome. And I'd never heard of it till about 3 years ago. Now it seems to keep popping up all over the place. Anyways, just kind of look at this. Okay, the last one we're going to do is sinusitis. Did a really good job here talking about the sinuses. Just remember that you are not born with your sinuses. They develop with age. So just kind of be aware of that. The risk factors, they've got some here. People with long, thin faces are definitely at increased risk for sinusitis, and you have to have your symptoms for at least 7 to 10 days before you can call it sinusitis. So typically what these people have is a cold, and then they're not getting any better, or they may start getting better, and then all of a sudden they start getting worse, having more, pain, fever, facial pain, whatever else going along with that. So look at these other kind of symptoms. The best way, or the most definitive way to diagnose this with a CT scan, but we're not going to do that for a normal sinusitis. You're going to treat it by the symptoms. Remember that a lot of times sinusitis will go away with just symptomatic treatment, like lots of fluids, steam, kind of cleaning out those sinuses and stuff like that. So they don't always have to be treated with antibiotics. Okay?